Dear Facebook Pure Urology viewers, urologists, good evening one and all from India and good morning from the other side. As you all know, we are discussing surgical technique based videos on alternate day by pioneers, experienced surgeons. Today we are discussing about the prostate enucleation. As you all know, the benign prostatic hyperplasia is one of the commonest disease that urologists come across anywhere in the world because it's a physiological change which produces symptom to the patients, and over a period of time in last 2 decades alpha blockers and the 5-alpha reductase inhibitors have come in big way that reduced, but what is happening is patient is using 5 to 6 years and 10 years, and during that time certain sector of patients will develop large gland and they will not be responsive and they will present with obstructive voiding symptoms and retention, which will become ultimately the indication for surgery. And surgery, the gold standard was monopolar TURP. In front of our eyes, significant change, even though statistics and papers may not support because of the large number of series on monopolar TURP there, it is impossible to go par with it, but bipolar TURP has almost replaced common private practice for the prostate gland in BPH. But now last 10 years we are seeing, even though the enucleation of the prostate is there for more than 20 years, initially, to be honest, today our speaker, Professor Dr. Fernando Gomez Sancha, is actually one of the pioneers who has used green laser very much enthusiastically in the beginning and developed the technique of the enucleation in the world. I must say. After that, he realized that the technology is changing. Accordingly, sir has moved, and his papers and his interest has moved to the holmium laser. So with this, what is happening is, irrespective of the laser technology, there is a technique also which we say that the man behind the technique is very important. Taking his vast experience into consideration, we are privileged and very happy that Dr. Fernando Gomez Sancha has accepted for this talk today. And when I have gone through the literature, he is really into this subject and has made a lot of contribution. Not only this, lot of videos to teach the youngsters, because we all felt when we finished 10 years back our MCH urology that enucleation is not at all a surgery which is easy. Enucleation causes incontinence. Enucleation is time taking. Enucleation is a costly procedure. Enucleation is only for large glands and not at all for medium glands. These type of bias will be there. Slowly we also thought, after seeing the conferences, that enucleation is a surgery which is changing the trend of management of the prostate. With this, I will briefly ask the career of Fernando sir. Good evening, sir. Welcome to the Pure Urology Talk group. Thank you for giving the opportunity. Good evening.
Good evening to everybody. Thank you very much for the invitation.
Sir, after seeing your CV, you are from Spain. You are born and brought up from in the country Spain.
Yes, I was born in Madrid.
Your medical schooling. Who is your mentor, sir? In your medical schooling, how you became a surgeon? Can you briefly tell?
Yes, well, I liked urology in medical school, and I went to a public hospital to do my residency, and then I spent 1 year with Tony Mundy in the UK, trying to become a reconstructive surgeon. But then I spoke to Roger Kirby, who said, there's not so much reconstructive surgery to do. The prostate is where urologists, the bread and butter of urologists. But I thought about it, and I started using green light, and then I devoted myself to laser prostatectomy.
Sir, I heard that green light you have used first time. What is the scientific research at that time which was involved along with you? Who was helpful to you in this production of the green light, the mechanics of the green light? How could you understand in the initial period?
Well, I was not involved in the development of green light. This was a development where the Mayo Clinic was very involved.
Okay.
So
in which year exactly it is used, sir? First, if you remember, which year it was very
I started using it in 2003.
2003. Okay.
Yes.
That time Homium was there very much active also.
Yes, yes, but I shared the same considerations as you. At that time, we thought holmium enucleation was impossible to learn, very difficult, only for very highly specialized centers. So it didn't look as a good strategy to start for a young urologist right after his residency.
Yeah.
That's why I chose Greenlight to start with.
Okay. So when the green light, what made you to go a little away from the green light exactly after 2003? How many years
Well,
you felt that it is very good, and then what made it that it is not good?
no, it was excellent in terms of hemostasis. We developed this anatomic vaporization technique where we would localize the plane of dissection to be able to vaporize the tissue down to that plane, and we were quite happy. But of course, it was not possible to do it in patients with larger glands. That's why we developed the enucleation, the Bloc enucleation for Greenlight, and I loved it. But I found that I wouldn't be a complete laser surgeon until I learned HoLEP. So I started doing HoLEP as well. And initially I was doing the 3-lobe technique, but I tried to adapt the en-bloc technique that I did with Greenlight to HoLEP. And the turning point was the moment when I had to operate my elder brother. I had to operate him. He had a nearly 100-gram prostate, and I asked myself, which tool do you prefer? And I thought, let's do it with Homium. And then, of course, I couldn't be insincere with anybody else. I really
agree.
The thing is that with Greenlight, you have to do a mechanical dissection, and sometimes the plane for mechanical dissection is not very good. And in those cases, you struggle a little bit more. Whereas with Homium, it's usually a very nice and very relaxed operation, and it is dissecting the plane for you. It's giving you very good hemostasis. So I felt, it was time to move on.
So when did you routinely started doing with Homium? 2007 something?
2010, I think.
2010. After that, predominantly your surgeries, or whether it is 100 or 60 or 120, is predominantly you like Homium laser or anything. This is the last question before I hand over to Manas for introduction. Do you think that these changes will be constantly happening in the technology, that we have to look? Now thulium fiber laser is coming. Already thulium was there, but not so competitive with Homium, because self-separation of the tissue because of the blast effect, as you said. Do you think that some more changes may happen? We don't know.
Well, we have just opened the door to pulse modulation. They have been able to do 2 consecutive pulses with Homium, and that has improved very significantly the cutting and coagulation properties. So I think this new pulse modulation idea will open the door to optimization of the tools, and I am sure we will see more and more improvements.
Yes, sir. With this, I hand over the program to Dr. Manas, who is very keen in learning the enucleation. He wanted to do every prostate in our group of hospitals, whichever comes. He says, let us do enucleation only. Let us not get tempted for TURP. That is the enthusiasm he has. It's privilege that Manas will introduce Fernando Josar. Manas, can you please introduce Professor Fernando? Now this is the program. Manas, over to you.
Yes, sir. Thank you, sir. Good evening, one and all. First, I'd like to thank Dr. Fernando Gomez Sancha for accepting our invitation, and it's our privilege to host you today, sir. Thank you. And Dr. Fernando Gomez Sancha is the head of the Department of Urology and Robotic Surgery at ICUA, Madrid, Spain. Actually, he is the founder of the International Greenlight Laser User Group, and he has developed the en-bloc Greenlight laser enucleation of the prostate technique. Initially, he was one of the pioneers of the Greenlight laser photoselective vaporization technique. Then he is also a director of the robotic surgery at his institution, and he initially worked with Professor A.R. Mandi in reconstructive urology. And he also works at the Hills Clinic in Sofia, Bulgaria, where he performs mainly the laser prostatectomies. Undoubtedly, Dr. Fernando Gomez Sanchez, sir, is one of those surgeons who popularized N-block technique. There's no doubt about it. And sir also has a YouTube channel on his name, in which the real life cases of, I think, nearly 29 cases he has uploaded, which is a vast teaching material for all the young enucleators. Thank you, sir. Thank you for your time. I'd like to give the stage to the Fernando Gomez Sanchez, sir.
Over to you, sir. Thank you, sir.
Thank you. Thank you so much. Okay, so I'll try to share my screen to start. Sorry, the video is advanced. Let's start from the beginning. This is my operating room.
Yes, sir.
And the patient's getting ready. This is an unedited case. And in this case, I was using the luminous pulse Morsellation system, the 120 watt laser. This is one of the two pulse modulation lasers we have. We also use the Quanta system laser. And well, this is a typical patient. We get weak prostate, catheter, and I will be narrating the video, but I'm happy to answer questions if there are any. For example, for patients with catheters, we have a protocol that we send the catheter to the tip of the catheter to the laboratory to make a culture, probably some days before the operation. And then we give the patient antibiotics for 3 or 4 days before the antibiogram. That is because there is always this risk of sepsis in these patients. And despite it's not very often, when you do a lot of cases, of course, you have to leave some of these cases, and that is what we do. We use this is the equipment I use. I use Richard Wolf equipment. I like it because it allows you to use the same external sheath for 3 instruments. You can use a laser scope, you can use a resectoscope, and you can use the Morsescope or the nephroscope that we use for Morsellation. And of course, the Morsellator, the Piranha system, I think it's very important to have a good Morsellator. So often we do transrectal ultrasound to evaluate the prostate. This case was about 80 grams in volume. He had a middle lobe going in the bladder, so we can take measurements and we can see if there's any anatomical abnormality that would not be detected without the ultrasound. Sometimes we see a clear BPH nodules invading the peripheral zone. We can see sometimes details. Also, as a teaching tool, it's nice. But also, I have to say, when you start your initial learning curve, I think it is quite nice to have a transrectal ultrasound in the operating room, because if you have a capsular perforation, for example, you can evaluate very easily if there is extravasation and if it's safe to continue or not. So there it is, a very simple instrument table. And let's hope to start the case. It's enough of this. There we are, getting ready. Now you have your microphone connected, I think, because I could use I could hear the typical noise from India, you know, the cars.
Yeah.
This is the instrument, and you can see that I like this instrument because it has a very nice tip that is quite blunt. So if you need to do a little bit of mechanical movements with the scope, it will respect the capsule. It would not puncture the capsule. And here, this is how we connect the camera. We get just getting ready. We do a white balance. And of course, I always have an Otis instrument. I don't know if you use it in India, but I think when you have a little bit tight meatus, for example, yeah, I prefer to do a 12 o'clock cut in the urethra with the Otis urethrotome than dilating concentrically, because if you have to dilate, you might damage the urethra circumferentially. And here you can see how the Otis is a nice thing because it makes a 12 o'clock cut, which is enough for the endoscope to go in. And this longitudinal incision might scar, might form a scar, but it's hardly going to stricture the meatus. So we don't see meatal strictures, really. That's the sternal sphincter. You can see some changes after catheterization. And this was the prostate, trilobar prostate, a very standard case. Not a huge gland, but well, what we usually get. And I guess in India, you get similar cases. Huh? That's
Yes,
the
sir.
of the fiber. Of course, doing these smaller cases are good for teaching, and they're nice videos. As you do bigger and bigger glands, sometimes the videos are not so beautiful. But I think it's nice to understand how the procedure is performed. I usually take off the guiding light. These lasers come with a light, and that's the apical region. And one of the drawbacks of HoLEP, as you mentioned before, was that there was a significant rate of postoperative stress incontinence. So my area of interest, let's say, has been how to prevent that. And I always thought that when you saw the classic technique, the 3-lobe technique, surgeons would go and dissect the lateral lobe very, very happily. And when you look back, the only thing left in the sphincter was the 12 o'clock mucosal strip, which means that the lateral aspect of the urethra is probably deepithelialized. So here, as you will see with this apical white line demarcation, here what I'm doing is...
Sir, can you pause? I wanted to ask a question here, if you don't mind.
Okay, go ahead.
You have given incision from 12 o'clock to 6 o'clock on one side. After that, you have directly gone to the developing the plane. You have not used any mechanical force here. Many of people just make a little dip with the beak and then they perforate the capsule. Is it necessary if you have a laser like 120 watts, or do you think that this mechanical force to break the capsule is necessary when you are using lesser like 60 watts laser holmium, or you never recommend it?
Well, that they say that the surgeons must have, and I will go back a little and play it again. And they say that the surgeons...
Go back a little, please. Very nice.
They must have the heart of a lion, the sight of the hawk, and the hands of a lady, of course. So if you do a little bit mechanical enucleation, you have to be extremely gentle. So it's not pushing to see what happens. It's more like dissecting. So you put the endoscope, and I think in this video, you will see that I do a little bit of that as well. Of course, sometimes you enter with energy. If you have doubts, you can explore a little bit with your tip. But of course, it is a dissection maneuver, which is very, very careful. Actually, what you do is you try to contact the capsule with your instrument and then slide it very gently. Right?
Okay.
So, yeah, be careful always. No, we have to be, we have to use the hands as if we were ladies. For some lady urologists who are watching us, probably you don't need to do anything because you're already a lady. So, yeah, there you go. So, here again, I am, of course, the objective of this technique is to protect the sphincter's mucosa. Because if you think about it, most studies on HoLEP who had big numbers, 30%, 25%, 40% even, of initial incontinence, but temporary. Of course, you wonder, how is it that the patient is incontinent for some time and then it gets better? What mechanisms cause this incontinence? And then, of course, you can think about, for example, stretching the sphincter. If you stretch the sphincter, maybe there is some incompetence for some time. No, just like if a football player or cricket player, gets injured, he has functional impairment of his muscle for some time. This could be one of the things. Of course, incontinence can happen because the patient has bladder hyperactivity, and sometimes stress can induce uninhibited bladder contractions, and the patient can leak, and maybe that is a mechanism. All right. If you remember,
I have a question, sir. Pause, please,
Yes.
if you don't mind, because this is a surgery. If can you pause, sir?
yes,
This is a surgery for the audience. If you go little away, then they won't come back. That's why I'm interrupting, if you don't mind. See,
okay.
now you have done mucosal incision from the top to bottom, and after that you are focusing on the floor only.
Yes, that's
You
right.
have gone nearly half centimeter to 1 centimeter on the floor between 3 to 9 o'clock position.
Yes, and I cut. Well, what I do initially, the first step of the operation is to mark the white line. The white line, I call it like that because the laser produces a widening of the tissue. All right.
Yeah.
This line is going to be the reference of the sphincter for the rest of the procedure. Then, of course, I connect the planes in both sides by cutting the frenulum of the verumontanum. And then I will concentrate to develop the posterior plane. All right.
Yeah.
So you can see
So
here.
you are not at all going anteriorly at all at this time.
No, because of course we want to approach the anterior aspect very, very carefully.
Okay.
So from below, in one side and the other side, we will meet at 12 o'clock. This moment when we can liberate the apex completely, this is what I call the early apical liberation. You have preserved the sphincter. The sphincter is totally preserved. The mucosa is totally preserved. Also, I have to say, when I did the 3-lobe technique, I was very stressed throughout the procedure because, the sphincter was always left for the end. Whereas here, once you liberate the apex in the first 5 minutes, 10 minutes, then you relax. The patient's going to be perfectly continent.
Okay.
As I said, as I was trying to explain, the mechanism for mucosal, the mechanism that probably explains why patients are incontinent for some time is that the mucosa of the sphincter is taken away from it. The sphincter is stripped from mucosa with the classic technique. Whereas if you do a very careful approach to the sphincter, preserving the mucosa, then the sealing effect of the mucosa when the sphincter closes will remain, and the patient will have immediate continence. All right. So that's the posterior plane development. That's the sphincter edge. And here, of course, the difficult aspect was how do I, because with the green light laser, being a side firing fiber, you could do this incision very nicely. You would point it towards the side, and then you would deepen this incision very nicely. So with the straight firing fiber, it's a little bit more difficult. And I realized that you have to cut a little bit. It looks as if we are cutting on the adenoma, but you have to cut a little bit the attachments of the sphincter with the apex. All right. So you deepen a little bit the white line against the adenoma. All right. Maybe for 3, 4, 5 millimeters. And then you gain a lot of access. You gain a lot of access because there are some fibers that are joining the apex to the sphincter. Initially, I tried to dissect the lower aspect of the apex. You see here, for example, it would look as if I'm taking the wrong plane because you see, I'm cutting on the adenoma. That's very confusing for people, huh?
Yeah.
And they say, okay, you're going to leave tissue behind. No, look at this. We are doing this to detach the sphincter from the apex, and then we will go and we will look for the good plane, all right? So that's the thing. Also, it is quite difficult to understand this by watching one case. So that's why I have uploaded many cases online without editing, trying to explain the mechanism. When I get visitors to Bulgaria, to these sessions, we get people visiting, they watch 30 procedures in 4 days or something like that. So the first day, they're a little bit confused. They don't understand what I'm doing. Second day, they have their aha moment when they start understanding, all right? Here, we are nearing 12 o'clock, and I'm very, very carefully progressing from below towards the anterior part, very carefully, and trying to stay always proximal to the white line that we marked at the beginning. Okay, that is paramount, so you don't. And here we're going to find the 12 o'clock fibers. You see the 12 o'clock part where we did our initial mark. And initially also you have to cut a little bit into the adenoma, because what you want is to detach the sphincter from the apex. And then you will see that progressively the laser is going to point more upwards, because of course the adenoma is going in the anterior part a little bit further up than the sphincter. So you have to sneak your way in that plane, carefully and progressively, always cutting the most distal attachments first. And here we are starting to liberate the apical anterior part of the right side of the patient. You see, this pulse modulation, it's quite nice. This is the white line again on this side. These are the 12 o'clock fibers on this side. Yeah, I don't mind as if I'm cutting in the prostate. It looks as if I'm cutting in the prostate. But you will see that at the end, we haven't left any tissue there. And I will show it to you with the ultrasound. You will see that it's a clean dissection. But of course, if we take the line of dissection a little bit more inside, a little bit further away from the sphincter, then we protect the sphincter much better. All right. The nice thing of this technique also is that if you think about it, when you do the 3-lobe technique, you are connecting with the bladder. So the field that you are irrigating connects with the bladder. Here we are irrigating a very small field at the beginning, and maybe there is some water going in the bladder, but if there is a bleeder inside this space, we're going to be able to coagulate it very nicely. The blood will be extracted and washed very easily. So the visibility is excellent throughout the procedure. And of course, if you understand the sphincter anatomy, here you can see the sphincter. You see how the apex is going further up than the sphincter, and we have to sneak our presence there slowly. When we try to put the scope on top of the apical part of the apex, what happens is that these fibers at 12 o'clock will verticalize a little bit, and then of course you can slowly get there. You have to be patient and you have to be very calm, in a meditative attitude, not anxiety, because this is a very technical operation, and if you follow the right rules and if you do what you have to do, everything is going to be okay. All right. So here again, I'm trying to cut the fibers at 12 o'clock. Of course, we don't want to leave apical tissue at 12 o'clock because we didn't follow the right plane. No, so it takes a little bit of work, at the beginning. But as I said, once you liberate the apex, then if you understand the anatomy of an orange, you can do this operation. It's very, very simple, because you're going to go around the adenoma with your laser. Typically, you have to position your endoscope to see the line of dissection, or the line of attack, as I like to call it. So you see that in every moment in the operation, we are seeing this line of dissection, and we see in one side the adenoma and in the other side the capsule. All right. So this is how you have to position yourself. You want to look at the line of dissection, you want to see capsule, and you want to see adenoma. Then, of course, another very important aspect is, where are you aiming with your laser? See, at the beginning, we are aiming towards the center of the line. There are 3 theoretical places where you could aim. You could aim right at the line of dissection. You could aim towards the capsule, which would be wrong. Of course, you don't want to cut the capsule. Or you could aim a little bit inside, in the side of the adenoma, if you know what I mean. So initially in the operation, until you reach the equator of the dissection, you have to fire following the line of dissection, because this is going to open the plane very nicely, and you can see how the movement is dynamic. You're not doing a very static operation. That's the sphincter. That's the mucosa on the sphincter. So we respected the white line, and this patient is going to be perfectly continent. All right. So here, of course, if you see a bleeder, you have to take it. Maybe sometimes if you leave a little bit of anterior tissue, you can then go back and take it out. All right. So it's not the end of the world. To me, the end of the world is an incontinent patient. But the rest is something you can perfectly. Well, it's not the end of the world, because these patients, when they have incontinence, they tend to recover over time. But some patients can be a little bit incontinent for 6 months or 1 year. So that's what we want to avoid. They call you every day, asking what's going to happen with my continence, and you try to reassure them, and it's quite tough. But we don't see that anymore. We don't see patients with incontinence. It's extremely rare. We don't do Kegel exercises. We don't recommend Kegel exercises. They are fine from day one. All right. So as I said, this is the orange. We are peeling the orange. And as the angles are going to change, we are dissecting a sphere. So, as we approach the bladder neck, if we are anterior, we have to tilt a little bit our dissection downwards, because we have to follow the curve of the adenoma. If we are below, we will have to point upwards, you see. So after this moment in the operation, the targeting of the laser has to be more inside the line of dissection. You don't fire against line of dissection, you fire very, very close to the adenoma, because if you are pulling the adenoma up, sometimes the capsule is going to tent a little bit, it's going to be pulled upwards. So if you fire against the capsule, you will open a little hole. So you have to keep the fiber very, very close to the adenoma. And if you go to one side like this, and then go to the other side, you have to bring it up a little bit more. So every excursion you make with your fiber, when you change direction, you go a little bit further up to keep extremely close to the adenoma. Another important aspect is that you have to use your energy so it blows very, 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 very gently over the tissue. This effect, this coagulating effect, and this dissection effect, you have to find what is the lasing distance that works best for the settings you are using. And what you have to try to achieve is a very soft effect that dissects, that coagulates, but doesn't penetrate too far. This way, if you go in the capsule, you're going to be, a little bit into the capsule, but not all the way. You know what I mean? So if you are careful with your handling of the scope and the movements of dissection, you're going to be able to judge. And this is your job when you're doing the dissection after the release of the apex. Your job is to be judging constantly the information that your eyes are receiving from the screen. You want to see what's happening. You want to judge the depth of the dissection, because the capsule doesn't always look the same. Sometimes we see a beautiful plane, sometimes we see an inflammatory plane, sometimes it looks, it's never the same. So you have to judge if you are leaving adenoma behind. In that case, you have to open your dissection so you can take the adenoma out. Or if you're going too deep in the capsule, like for example, in this area, you see that it looks a little bit flimsy, then you have to correct, you have to change. Continue firing close to the adenoma. And this way you can complete the enucleation with minimal risk of perforation and minimal risk of trouble. Here we are in the posterior aspect, entering, I think, the middle lobe pocket down there.
The entire surgery, your laser fiber is at 12 o'clock, even at the floor, just because you wanted to be close to the prostate gland?
Yes, you see some surgeons who do HoLEP are changing the camera, are moving the fiber. They tell you, for example, if you are firing at 6 o'clock, the fiber should be at 6 o'clock.
Yeah.
12 o'clock, the fiber should be at 12 o'clock. And to me, one of my obsessions has been to simplify the procedure, When you want to teach someone that he has the pedal, the difficult anatomy, he has to rotate the camera, everybody gets lost. Whereas if you keep the camera true, okay, what you see, it's what you would see if you were standing there, you know, it doesn't rotate. Because if you have your fiber, let's say at 3 o'clock and you rotate the camera, it could look as if it is at 12 o'clock, no? So you keep the camera straight and you keep the fiber straight. And I saw that for the beginning, for the posterior dissection, this is the entry into the bladder here.
Yes, yes.
We find these vertical fibers of the bladder neck, and we know that this is a pathognomonic sign that we can enter the bladder anteriorly. Now, of course, this wonderful irrigation of a small space changes a little bit. If there is bleeding, you know, you want, there will be blood going in the bladder, of course, and then it will be more difficult to have a nice view. So my advice is, if before you enter the bladder, complete your hemostasis, because that way, when you open up, you will have good visibility. That's checking for the UO. And you see, this is a real life case. You can see that how long it took, but 20, 25 minutes, something like
Fantastic.
that. So you don't need, of course, I have done thousands of cases, but I have to tell you, it's very frustrating that after so many years working and hard, you know, and trying to understand anatomy and everything, when I teach someone to do this procedure and I watch them doing it after some time, I think, wow, it was not so difficult for them, you know. So
that's a pleasure for a mentor.
This is something you can learn, and this is something you can do, and very proficiently. And I have to tell you, I know that in India you have an enormous surgical volume, and you are truly surgeons. You know, in some hospitals in our part of the world, people would go to the operating room once a week or something like that, whereas you're every day, I think, working, operating, doing what a urologist does. No, but I tell you, this is a very enjoyable operation. This is a very enjoyable operation. You become a fan of it. You love it, and the feedback from the patients is so amazing. They're so happy, and it really, when I go for dinner after work, you know, I can drink wine because I know nobody's going to call me in the middle of the night. You know what I mean? It's a very nice. It's a very nice operation, and it really changes everything. One important.
It looks like you are not at all using your thumb into the mechanism of front and back. You are using you are using just like one piece. You are not at all using your front and back mechanism.
No, you know, it's very common when we invented the radio, the TV, you know, was the radio. So the first time they did TV, they thought, let's film someone with a piece of paper and a big microphone, and let's broadcast this on TV, you know.
Okay.
Because they didn't have the imagination to realize that they could do, you know, the Big Brother on TV. You know what I mean? It took many years to develop this understanding. And the same happened when Holmium started. Someone had the idea, Kunz, I think, the German professor, had the idea to develop a trigger like a TORP device to move the, you know. And but I think this is a wrong idea. I prefer to hold the fiber with my fingers. You can see it on the because that gives you the sensitivity to become closer or push the fiber inside when it's needed. You see, so it's a very dynamic manipulation of the fiber, and you adapt to the tissue, and it makes your operation much more precise. So that's what I recommend.
In that case, I'm just imagining, can you use a 18 French nephroscope in your hands, which is smaller, if the urethra is small, and then do the same job if it is 20 degrees angulated, I mean telescope?
Well, I don't know if the nephroscope allows for continuous flow.
Yeah.
But, you might need to put a suprapubic or something to allow for some outflow.
But you are not using the you are using left hand only to hold the instrument, that's all.
Yeah. The left hand drives the instrument, and the right hand, of course, the two hands are working together, but you can see that I use my fingertips. You see,
Yes.
I don't
Yes.
do a big pressure and I don't do hard movements. This is now the final hemostasis.
Fantastic.
And yeah, you see, it's a very fast procedure. And I have to mention something. It's very important, and people underestimate this. This is a teamwork, you know, because you have to change instruments. Sometimes we have to use a resectoscope. Look at the sphincter.
Yeah.
Preserved. So now we are preparing to change for Morsellation. And here's where the team helps you. You know, you cannot invent, oh, this is the ultrasound. Here you can see
Oh,
rectal ultrasound, the quality of the resection. There was a little bit of tissue at 12 o'clock here. You see? So
yes.
the ultrasound never lies to you.
Yeah.
But if we look at the side view, all right, or longitude view, you can see it's a very nice fossa.
Yeah.
Sphincter preservation was very good, so we were quite happy.
Yeah.
As I said, teamwork is paramount, because if there's any morsellation problem, you can see that you cannot operate the morcellator. You are scrubbed, you are by the patient, so you need your people, your nurses, to do it. All right. So this instrument change, for example, now we change from the laser cystoscope to see how my nurse is helping me. Take it out, I go in, so we don't decompress the bladder too much, and we can move on very fast. Now I'm filling the bladder while the nurse is giving me the morcellator with the blade. And if you have a nicely trained team, then you will minimize the problems. All right, now the bladder is full, morcellator is going in, and I'm getting ready for morsellation. So teamwork is the key word. I remember circulating nurse, I told her, keep the bags full, keep the water running, especially during morsellation. But she was new and she didn't know that she had to puncture the bags all the way. So the tip of the tubing, didn't go into the bag. So when I looked, the bags were full, but there was no water going in, So the thing is, even the circulating nurse can have an impact in the result of the operation.
Yeah.
Of course, everybody was frightened about morsellation, but I have to say, if you do good hemostasis, if you're careful, and this is the standard positioning, you can see the tissue is at above, okay, at 12 o'clock.
12 o'clock.
You see the blade, but the blade is not too close to the lens. Many people are afraid to push the blade inside because they think that increases the chances of catching the bladder. But you see there are two black triangles around the blade on the lower part of the screen. There are two black triangles. If these triangles are black, it means that the bladder wall is far away, all right? So you need to push the tip of the morcellator at least to see these triangles. If they become pinky, then you're getting close to the bladder, and then of course you have to change your position. You have to feel the bladder better.
Very good. Very good.
Yeah, so
that black is nothing but a distance away from the wall so that you don't see anything. It's a dark room.
It's a dark, and it's protective, okay? So it tells you that you're not close to the bladder wall.
Yes.
The irrigation has to go in. And then, of course, you have to be very careful because you see now the morsellation is efficient. We are seeing that the morcellator is covered with tissue, which means that there is little water coming out. There's water coming out, but not too much. If you have inefficient morsellation, you will see the mouth opened. So if you keep sucking, the bladder is going to be emptied very fast. Okay. So, if there is an inefficient morsellation, be very careful and stop for a moment. Don't keep the pedal on when you can see the inside, when you can see the mouth, the jaws of the blade. You know what I mean? Because then you will empty the bladder. Of course, you can palpate the bladder if you want throughout the procedure to check that it's full. One of my colleagues, when he started doing HoLEP, he would have the nurse with an ultrasound probe checking that the bladder was full. I don't think that's necessary, but you have to be conscious as this is an operation where the surgeon has to be present. You cannot be thinking about your holidays or what.
Especially this part.
Yes, you cannot be thinking on other stuff. You cannot be thinking on your daily problems. You have to be present in the operation. When you're doing the holmium phase, the enucleation phase, you have to be analyzing the information, the direction of the fibers of the capsule, the depth of the dissection. Am I leaving tissue behind? So what is the distance that I'm using from the fiber to the tissue to get the effect? Is the effect good, or can I make it better by modifying the distance or the speed of my movement? No, you have to be actively thinking and observing and learning, because this is what makes you a good surgeon and what will help you. And the same with the Morsellation. You cannot just look to another way. Yeah, you have to be very present and very careful and look at the details. And you have to be thinking how much water is coming in, how much water is coming out. For example, I don't use a second inflow. You can see I have only one inflow. And typically many people use two inflows. And that is because I have this balance in mind, all right? Also, maybe the valve system has a better balance than between the water that enters and the water that the morcellator sucks than other systems. You would have to see what happens with your system. But if you do the test, you fill the bladder, you put the morcellator blade in the bladder neck area, and you start sucking without sucking tissue, you will observe how fast the bladder collapses, all right? When the bladder wall is totally distended, it's very difficult that the suction device will suck the mucosa into the mouth. Of course, you see that I'm always looking up with my instrument. I never rotate it to one side or the other because that increases the chances of catching the bladder. Look how safe it is. I'm sitting on the bladder neck almost in contact with the bladder neck, and there is no catching the bladder at all, you see? So, but if you leave the bladder to collapse, then the suction can take the mucosa, and then you will have an accident.
Yeah.
Also, one thing I want to say, and it's very important, especially for people who are starting, if you get to a point where visibility is not good, if you think about it, when you distend the bladder in a cystoscopy, it starts bleeding, all right? So if you keep the bladder distended for a long time, it's going to bleed, and maybe it's difficult to get good visibility. So that's why I think it's good to have a good morcellator, because then you can morcellate and go. But if you find in any HoLEP procedure a moment where you're out of your league, you're out of your depth, you cannot handle what's going on, the best thing to do is to put a catheter and tell the patient it was not safe to continue, all right? The patient will tell you, thank you very much, doctor, that you didn't take unnecessary risks with me, And then 2 or 3 days later, you go back, you finish your work. If there was bleeding, the bleeding stopped. If there was any problem, but I have had to do that a couple of times in my life, but I would do it again. If I find a case where there is a problem that I cannot assure that it's going to be safe to continue, then put a catheter in and go. And then you will avoid any accident, which should never happen. So this is it. This is the case. The patient was sent to the room with a light irrigation. The nurses in the rooms tried to stop the irrigation if it's possible. And then the next morning, we have a protocol to remove the catheter. We tell the nurses to wash the bladder. We tell the nurses to deflate the balloon, pull the catheter out 4 centimeters. So the tip of the catheter is going to be in the fossa, and typically there are clots there. So they can wash the clots, and when the urine comes out clear without clots, they fill the bladder before they remove the catheter. So the first void is going to be immediate, all right? So they put 250, 300, and the patient voids immediately. And then they give the patient 20 milligrams of furosemide, and then, of course, after 2 or 3 hours, they can go home, all right? So this is it, this is the video. and I'm
Yeah,
happy.
fantastic. Entire thing is unedited video.
This is an unedited video. You see, it was 40 minutes total time, a little bit less than that. I think we are going to weight the specimen. So you can see, but you can see that the water coming out is quite clear. There is no drama. The patient is happy. The nurses in the rooms are so happy. The anesthetist is reading the newspaper. You know, he doesn't even need to be there because he knows the patient's absolutely safe. You know what I mean?
Yeah.
It's a great operation. We don't have stress. We are calling for the next patient, you know, and this is the tissue basket. And we're going to try to weight it to show you how much tissue we were able to remove. So it's no longer an operation of 3 hours duration. You know, it's no longer a dramatic operation. It's usually relaxed. We do five cases in one morning session or one afternoon session. So for example, we start operating at 3 p.m. and by 8 or 9 o'clock, usually we can do 1 hour per case because we change the patient in 20 minutes and operations take an average of 35-40 minutes. So of course, if we do a very large gland, it will take longer. So now she's waiting, she's trying to weight the empty thing to subtract it from the total weight. So this was not a very large gland, but we have done 200 grams of tissue in under 1 hour of surgery. You know, this is when everything works out really well, but it's incredible. And these patients go home the next morning. So it was 61 grams of tissue. Probably the prostate was 80 grams or 85 grams in volume. I guess some of the tissue is vaporized. Some of the tissue is crushed with morsellation, but well, it's a nice operation. It's a nice cavitation of the prostate, and well, I think everybody should really invest some time and efforts to try to do this. You can do it with a bipolar system. You can do it with a laser. I work in Bulgaria with a low power laser at 36 watts. If there are stones, we break the stones. And then we do the prostate. If there is a concomitant bladder tumor, we would do the enucleation first, and then we would resect the tumor. We have done ureteroscopies as well. So I'm going to stop the sharing of my screen.
Right. So we will take some questions
Yes.
based on the audience questions. You have done little exaggerated lithotomy position. Do you want to comment on the position, or it doesn't make any much difference?
No, I use a social lithotomy. It's right angles.
Right
The legs are following right angles, and so I don't think forcing the lithotomy is necessary.
Yeah. The size of the nephroscope, the working element and the outer inner sheath is 24 by 26.
We have two systems. We have a 26 and we have a 24.
Yeah.
So we can use, when the urethra is a little bit smaller, we use the 24. There is a Brazilian urologist who is using even 18 French or 20 French instruments for enucleation. And if you think about it, with these new pulse modulation lasers, which give you excellent hemostasis, we will see a tendency to reduce the size of the scopes.
Moses effect. Do you feel it is obvious because there is a 100 watts laser, there is 120 watts laser from Luminous. The Luminous claims Moses effect is the speciality of the laser, but the majority of the pioneers in laser says that there is no effect like that. It is only the pulse width which has come into the picture. If you make short or long pulse width, the same effect can be reached with 100 watts also. A comment on that?
Yeah, I have heard that people who use long pulse width get a very nice hemostatic effect. But, well, you know, I think pulse modulation carries a big advantage in terms of cutting better and coagulating better. But as I said, in Bulgaria, we use the standard holmium 36 watts, and we do huge glands, 300 grams we did last week.
What are your laser settings in holmium for with 60 watts laser, that is 35 watts effective?
Yes, we use, I think, 2 joules, the same.
Okay.
It's about 18 hertz only.
18 hertz.
Yeah, the problem is, I mean, you can do higher settings, but these lasers tend to heat up and stop because you're lasing continuously. You know, most of the time in the operation you are dissecting the plane. There's no stopping time.
When you pass the laser fiber in a neutral position, it comes at 6 o'clock, if I am not wrong.
Yes.
You are doing 90% of the procedure with laser fiber at the 12 o'clock position.
Yes.
And you are using in the opposite direction to do it entire sweeping. Especially on the top side of the prostate, you are using the laser fiber at the 12 o'clock and then going with the gland.
Yes. Yes, of course. As I said, the idea is that you want to simplify the procedure.
Yeah.
So in some moments, maybe if you had the fiber at 9 o'clock or a little bit to the side, maybe it would be a little bit more comfortable or easier. But that would be at the cost of having to move your hands and to, you know what I mean, making the procedure more difficult. So I chose the 12 o'clock position, and I keep it there because it simplifies very much the procedure. And when people are learning, they also are happy to know that what they see in the screen is what it's happening inside.
Okay. Do you have difference between, I'm asking an important question because I do also enucleation with thulium fiber laser. Apical release early versus mucosa complete release early. Is mucosa incision necessary all around, or you can do half of the gland, then develop the groove and then cut little mucosa, and develop the groove, then cut little mucosa, and then in the last part you go proximally so that you leave the plenty of mucosa. I mean to say, initially only you have incised the mucosa. Some say that go deep of 1 centimeter mucosa. Some say that there is no need, just cut at the on either side of the veru and then slowly cut the mucosa.
I think the relevant aspect is that if at the end of the procedure the mucosa is lining the sphincter,
okay,
I think the patient will be okay. How you manage that, probably it's not so important. I have done 3-lobe technique, but marking the 12 o'clock white line around the apex at the beginning. And by doing that, I get the same results in terms of continence. The apical release, I think, contributes to stretch the sphincter a little bit less. Because if you think about it, once the sphincter is released, when the sphincter is, if this is the sphincter,
yeah,
once the sphincter is totally released, when you move the scope up and down, the sphincter is going to go with the scope. Whereas if you are working in one lobe and the sphincter is still attached in the other side, maybe you're forcing a little bit of distension of the sphincter. So I don't know, but I think if you preserve the mucosa, no matter how you do that, but of course, if you do it at the beginning, then you have a very nice landmark, because when you start operating, there's some bleeding, the visibility is not so good. And then if you want to go and know exactly where the landmark was and you want to mark it then, it's going to be more difficult. The thing of the procedure is very tight.
Yeah.
But as you start moving around, it relaxes, you know, and then maybe the anatomy is so clear.
If the anterior lobe is not very thick, it is separated just by the lateral lobes. When you are planning en bloc, sometimes you will break the mucosa in the center and you will find again going back to the retropubic region easily. If it is thickness, some thickness is there, you can, like you have shown parallelly, you have gone and just blue dome and then you entered in the center part, in the later on you came. But sometimes if you miss that, you will convert it into bilobar.
Well, of course, if you have that, then you have done a 12 o'clock incision. No, or you can complete it, and then you will do the incision, and then you can still do en bloc, but instead of having a total complete donut, you will have a horseshoe.
Horseshoe type of.
Yeah.
Nice.
It's not a big deal. I think the most valuable aspect of this en bloc approach, I think, is the protection of continence. The rest is a matter of personal taste. You know, whatever you believe in, whatever you want.
If too much large lobes with a median lobe is there, even after experienced surgeon is planning for en bloc, when one lobe is pushed, other lobe gives resistance. Instead, if the at least the median lobe has gone into the bladder, then some amount of the space will be there for you to act. What is your comment on more than 150 grams with a median lobe?
Well, you know, when I see a very big middle lobe in the bladder, I'm very happy, because it increases the volume of adenoma significantly, but it doesn't increase surgical difficulty. If you think about it, don't interact with the middle lobe at all. You know, we are just dissecting the amount of tissue that is in contact with the surgical capsule.
Okay.
Right? So whatever is inside the bladder, it really doesn't matter. It doesn't change what you do. So, for instance, if I have a big gland with a big middle lobe, and I push down my scope too much to enter the bladder, you know,
yes.
I don't enter the bladder. I avoid doing that, because many times when you do that, you split the sphincter at 12 o'clock. You know what I mean?
Yeah.
You might cause incontinence because of that. So what I do is I start the en bloc enucleation, and even in prostates where there is no reach into the bladder because of the length of the prostate, you always can reach the bladder neck from below. You know what I mean? So the bladder neck, the middle lobe is not a problem. And what I have done in the very large glands, when it's difficult to push the adenoma in the bladder, is you can very fast split it in two. You know, you do a 6 o'clock incision in the adenoma, you get inside the proper prostatic urethra, you cut. This is already a vascular tissue, and then it gains mobility, and then you can push it in the bladder. Also, sometimes I have done intra-capsular morsellation. So if you have a big piece in the capsule that you cannot luxate into the bladder, you can morsellate inside the prostatic fossa.
Okay. Before completing?
No, at the end, of course, you have to complete the dissection.
Okay.
But as I said, you can always, in the very difficult cases, you can always resort to things that you wouldn't do in the normal cases, like incise the adenoma. But I'd rather incise it at the end, when the prostate has been mostly dissected off the capsule, than to do an incision at the beginning, when it's going to bleed more.
If the median lobe is going intravesical median lobe, what are the tips? Like, do you distend the bladder to avoid the ureteric injury when you reach the margin of the bladder neck to the bladder, and you will follow that mucosa from one end to other like a hockey stick? Any tips to inadvertently you will be closer to the ureter most of the times?
Yes, in the big middle lobes, the distance gets very close, and you have to look at the UO to check where it is. There's no other way. Of course, we enter anteriorly, and then we cut the bladder neck.
Yes.
So when you get to a point where we think I can go in and look at the UO, you have to look at it and cut medial to it, of course.
Okay.
In the case that you do UO injury, in my experience, it hardly ever produces any problem, because holmium has a very shallow penetration of the energy. So probably it would be much worse to do it with green light, for example, that penetrates much deeper. But with holmium, if you see that you got too close to the UO, or even that you sprayed a little of the UO with energy, most of the times I think you can leave it as it is and just monitor the kidney postoperatively, and nothing will happen.
Okay. Manas, you want to ask any questions? Otherwise.
Yes, sir. Sir, you also used that bipolar Hermann loop for en bloc early apical release enucleation. What is your experience about that, sir?
I haven't got a lot of experience with bipolar.
Yeah.
I have done a number of cases with the companies that bring the instruments for me to try. And well, it's perfectly feasible. If you want to do bipolar, I think there's already data showing that it's a safe procedure. I don't like the way that most people do bipolar, in the sense that many people, for example, resect the middle lobe first, and then they try to enucleate. I would recommend you to, if you're going to do bipolar, to do an en bloc technique as well, because it's perfectly feasible. And if you start resecting, then the visibility is not good. You know, it's different. Of course, if you don't have a morcellator, you can do bipolar enucleation. You leave you tilt the adenoma into the bladder, but you leave it hanging from 6 o'clock or connected to the 6 o'clock pedicle, and then you can resect the adenoma quite safely. It's usually bloodless, but of course, it's not very practical in very, very large glands. So, you know, when you're going to talk to a manager of the hospital, and you are Chandra, you're a manager.
I'm also a urologist.
Surgeons come to you saying, why don't you buy this equipment or that equipment? No, but I think the question is not to go to the manager and say, I need you to buy me a morcellator that costs, I don't know, this money. I think that you have to communicate with him. We could do the open prostatectomies or the TORPs, we could do them almost ambulatory, you know, with less than 24-hour stay. We don't need to transfuse patients. The high-risk patients are going to do much better, you know. So when you make the picture how your department would look like when you have already adopted this technology and when you can do it, then of course the investment looks very silly. You know, a morcellator cost is not so much. And also, I would also ask the manager to save a little money for training. You know, go to one department where they do good HoLEP and learn from them. You know, watch how they do it. And this costs a little bit of money. So if you're going to make an investment in a laser,
Dr. Manas will come to you, sir, for few, if you permit.
Welcome to come and visit if you want.
Yeah, he is very fan of you.
Anytime, anytime you want.
Yeah, Manas, any more questions?
No, sir. Thank you, sir. Thank
Sir,
you. Thank you for the excellent presentation.
Excellent presentation, sir. You involved in that, and you are mentioning the time, and you are so practical. Very few European surgeons have shown this live completely like this, and you are really involved in the surgery and shown the common points. Only thing is, the honestly last comment I wanted to make again, being a urologist for last 15 years and being the owner of 3 hospitals, now I know that 120 watts laser is still not very cost effective in India. That is where people are looking your video next time whenever you go to Bulgaria. This 60 watts laser, how you do it? Will the tissue get separated so well with 60 watts?
Because you use 2 joules, so it's the same pulse. There's less repetition, so it's instead of trrr, it's more like tack 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 tack. But it opens the plane very nicely. Maybe the hemostasis is not as good when you have to use it. And
speed of resection, sir. It is 30 minutes is too much. We have never heard 30 minutes enucleation, even if it is 80 grams. 30 minutes is too short time. That saves everything, money, the time, everything it saves. But is it possible with 60 watts ever?
We can do very fast times as well, but we are faster with Moses and the laser from Quanta System as well. There are 2 brands providing this pulse modulation now, and we are a little bit faster, but we do fast operations. What I told you before about 200 grams in 1 hour was with the low power laser. So you can perfectly do fast operations with a low power laser.
What we observed in TFL is like after releasing the mucosa and apex, then if we use mechanical force, a lot of gland gets separated, and in between if you use the laser, then it may be faster, but I doubt how much amount of the traction we are putting, even though it is released on the sphincter axis and even the stricture. As a matter of fact, in your case, hardly I have seen any forward and rotational movements. I have not seen single time in this video. I hope in all the cases you are doing only just rotation. It's clearly ladies' fingers.
It's a fingertip operation.
Yeah.
very, very gentle operation.
Very gentle operation you are doing. That's why you are saying incontinence is 0. So you need a
Never, because if you look at the population of the 65-year-old men, incontinence, it's
oh
already,
my God, not even a day we cannot convince.
it's very rare. We don't have patients who have to wear pads for months. You know, it's very unlikely that this will happen.
Great, sir. We learned that ladies' fingers is a very important point we could observe in your dissection. Fantastic. I really we have a lady urologist with us also. Hopefully she'll do better job. And thank you very much for being with us. And if possible, maybe a couple of months afterwards, we love to see the same unedited video with 60 watts, sir. If you are kind enough.
Then we can do that. Low power
Low
enucleation.
power enucleation, because that will be very, very interesting for all of us because it's cost effective.
Brilliant.
Thank you very much. Great.
Thank you very much for your attention, and